Hello everyone and very good evening to all. And I'm starting the lecture now, and the lecture is named as everything about the Capsulorhexis. But there is a disclaimer here that I will not be talking about of course, the femto CCC. I'll be talking about mainly the manual Capsulorhexis methods. So let's begin the lecture with a short small poll so that I know what is the experience of the participants as far as cataract surgery is concerned. So you can enter your numbers in, I will give you another 10 seconds. All right, so I think we have fairly mix of experience as well as beginner surgeons who are there. So I think we'll go to the next poll, because I want to know which is your preferred instrument for doing Capsulorhexis. I'll give you 10 more seconds. All right, almost 90% are using cystitome, and that's perfect. Also, few are using Utrata and microcapsulorhexis forceps. I'll be talking about both of these. And let's have a poll regarding what is the preferred choice or what is the usual choice of OVD that you use as a stock OVD. Of course, in special circumstances, you may be using some other OVDs, but what is the commonly used OVD in almost 90-95% of your cases? I'll give you 5 more seconds to answer that. Okay, so most of the surgeons are using, as expected, 2% HPMC, and that's quite obvious because it is the least expensive one. All right, so we'll begin with our presentation. My presentation is basically based on understanding the physics and understanding the concepts behind doing the Capsulorhexis. So we'll start with the presentation now. Okay, so continuous curvilinear Capsulorhexis is also called as CCC. Very important, I think, technique which was discovered by Dr. and owe a lot to him for describing this technique. So let's start with the understanding of anatomy of the anterior segment. Because whenever we are doing these exercises, we must know what are the exact dimensions that we are looking at. These are the usual dimensions of anterior segment. Diameter of the lens on which we are going to do capsulorhexis is around 8 millimeters.
There is a lot of sound
And
disturbance.
then the thickness, which is at birth around 3.5 millimeters, it increases gradually with age. Is there a problem with the audio? I think some of the participants have kept their mute them. Now is it audible better? It's a request to all the participants to keep their mic muted so that my voice is clear to all others. Okay, I hope now it is clearer. So I will again begin. Thank you. Okay, so I will begin the lecture again.
Mute and
All of you mute your mics.
Mute your audio.
Okay, request to all that please mute your mics so that it is clear for everyone. Okay, also you can switch off your videos so that it doesn't affect the live streaming. Now is it better?
Yeah.
Okay, so kindly mute your mics so that everyone can hear me better. Okay, so now looking at the lens, what you see here is that the diameter of the lens is around 9 millimeters. So that's the diameter we are looking at. And the thickness is around 3.5. Kindly mute your mics, please. And thickness is around 3.5 millimeters at birth, and then it gradually increases over time with the age. So basically, when we are looking at the anterior capsule, we are looking at the diameter of around 9 millimeter of the anterior surface. Now, out of that 9 millimeter, if you look closely, there are zonular insertions on the anterior surface of the lens. So the actual available area of the anterior lens capsule is around 6.5 to 7 millimeter. And that's very important. Whenever our rhexis goes into this zonular attachment, which though usually start after 6.5 millimeter, but in certain cases, they may even start at 5.5 or 6 millimeter as well. And then you may have resistance. Also, there is outside pulling of the capsulorhexis edge. So that must be always kept in mind. Now, this is something from the physics that we must all understand. If you see the anterior surface of the lens, it is convex. The centermost part has equal, I would say, forces acting from all sides by the zonules and because of the elasticity of the lens. And as you go from center to periphery, what you will find is that the outer vector of the forces will go on increasing. In the same way, because it is a convex surface, you can imagine that as you go down on the slope, the outward pull is going to increase. And that is the reason why when your rhexis size goes above 5.5 to 6 millimeter, you will find that the rhexis edge is slowly going outwards towards the zonules. And that's because of the natural pull of the zonules over the capsulorhexis edge. And this is more commonly seen with intumescent cataract because there is increased intralenticular pressure and anteriorly the lens is very convex. Also more common in small eyes, the same way in pediatric eyes because the anterior lens surface is very convex. Also, the zonules are highly elastic and so is the sclera. Whenever you are looking at the rexis size, you should always be looking at the size of the rexis. Now, for example, here, the rexis is going on fine. But if you look at the size of the rexis or the distance of the rexis edge from the center, it is way beyond 6.5 millimeter. So obviously, if the surgeon continues to do rexis at the same diameter, it is likely to extend further. And if you remember the previous slide, the outward forces are going to be more and more as the rexis edge passes beyond 6 millimeters. Another important thing to understand is how you use the OVD to balance the posterior pressure and intralenticular pressure. So when you use OVD with high molecular weight and higher specific gravity, you are basically putting pressure on the anterior capsule and thus you are counteracting the intralenticular and posterior vitreous pressure. But if you use a OVD of low specific gravity like 2% HPMC, and it is a common tendency if you feel there is more upthrust or there is a raised intralenticular pressure, or if when the capsulorhexis edge going outside, you tend to push methyl cellulose a lot in order to increase the anterior chamber pressure. But it may become counterproductive if you stretch the anterior chamber too much, because as you stretch the globe, you also push the lens back and you are also increasing the vitreous pressure. And that is the reason why many times when the CCC is going outside, if you push more methyl cellulose, it might extend because of that push. So in such cases, it is better to use a high molecular weight viscoelastic, something like Viscoat or hyaluronate, and do not never fill the anterior chamber excessively. It will be counterproductive. To explain this concept, just consider the globe as a spring, because though it is a rigid structure, it has some amount of elasticity. And there is also vitreous, which can work like a spring. So when you are excessively stretching the anterior chamber, the vitreous gets compressed and the sclera tries to expand. But the moment it's released, it is going to push everything anteriorly, and that is going to extend your capsulorhexis further. In case of shallowness of the anterior chamber, because the vitreous is leaking, the opposite happens. That is, the anterior chamber pressure goes below the vitreous pressure, and that leads to further outward extension of the capsulorhexis. So these are the physical forces that you should always be thinking about when you are doing capsulorhexis. So here I would like to just highlight, excessively pushing lot of methyl cellulose may be counterproductive, and also vitreous leak happening from an open anterior chamber or during the maneuvers is also counterproductive while doing capsulorhexis. The same is true when the sclera is more elastic and if there is a more vitreous pressure which is there. And sclera is more elastic in younger patients, as we know all. So this is what happens when there is leakage from the anterior chamber. When you are doing CCC, you have to center it around either the Purkinje image, which we consider as a marker for the visual axis, or in some cases where the patient is not able to fix, we may have to take center of the limbus as the center point of the CCC. Some surgeons also mark this with small gentian violet dot, but you can also mentally note where the Purkinje image is or where the center of the limbus is, and then you try to center your capsulorhexis around that. Now, this concept is a quite old concept. Everyone knows that, but in further slides and further cases, this will be useful for you to understand why certain things are happening. So we use mainly two types of forces to forward the capsulorhexis edge. One is shearing, where we are pulling the rhexis or the capsule flap in a tangential manner so as to tear it further. And second is tearing, where we are pulling the capsulorhexis flap centrally, so that it tears further. So if you understand from this, for tearing, we need stronger zonules. So for example, if you consider a case where the zonules are weak or the capsule is redundant, if you are doing tearing, that means you are trying to pull the flap centrally, what it is going to do is that it will not lead to capsulorhexis extension, but it may pull the zonules itself towards the center and may increase the zonular dialysis. And also it may lead to extension of the capsulorhexis into zonules because now zonules are being pulled. So remember, whenever there is zonular weakness or the anticapsule is redundant, always use the shearing forces and not the tearing forces. Overall, shearing forces are better controlled as compared to tearing forces. We'll see this also in congenital cataract, where the opposite need may be used in order to control it. This is one, I think, good idea. I think this was published by Dr. Zheng and Gao et al. And this is the use of 3-bend cystotome. It's like more of a ergonomic, use of the cystotome. And I particularly recommend it when you are doing capsulorhexis through the main incision. That means through the larger incision. But if you are using the side port incision, smaller incision for doing capsulorhexis, it is better to use our regular 2-bend cystotome. Staining the capsule with trypan blue is, I think, a very essential step, particularly if you are learning the surgery or learning capsulorhexis, because it improves contrast. So when you are learning, many times you disturb the cortex because you don't have control over your instruments, and it may hamper visualization, even in cases where the retroillumination is good. So it is better to use trypan blue staining. Also, studies have shown that it also reduces elasticity and increases the stiffness of the capsule. So it may have some additional benefit in doing your capsulorhexis. But remember, the contact time should never exceed 30 seconds. In fact, 10 to 15 seconds is more than enough. And try to stain it under air so that you get good staining of the anticapsule. So let's begin with the actual CCC, the steps. So this is how we are going to use our cystotome. Most of us use 26 gauge needle and bend it. Bend it at two sides. One is at the tip and second is at near the hub. Now the tip has to be bent exactly 45 degrees. Why exactly 45 degrees? Because when tip is bent 45 degrees, it gives good visualization of the tip. So you know where you are holding the flap. Thus, particularly in the subincisional area, it is of use because you are actually seeing where you are holding the flap. If it is bent too much, then you don't have proper visualization. And if it is bent less, you don't have proper control over the capsulorhexis edge. For the beginners, I recommend making two side port incisions. around 0.8 millimeter size. So we don't need very large side port incisions. This reduces the risk of visco leakage when you are doing capsulorhexis, and that is paramount because it keeps the anterior chamber stable. All the vectoral forces over the capsular edge is very stable, and there is no outward movement of the capsulorhexis edge if the anterior chamber is well maintained. So begin with, pierce the anterior capsule near the, as we said, near the Purkinje image or at the center of the limbus. I will show later how to use a Capsulorhexis marker as well. And after tearing, make around 2 millimeter radial tear. Now, why it is important to make the tear exactly near the center? That is because the first moment where you create this radial tear and then you lift the flap by going slightly under this tear and pushing it upwards is the most uncertain step of capsulorhexis, the procedure of doing capsulorhexis. You will realize it. Because if you are starting this at the periphery, at the moment you lift up this capsulorhexis edge, you may have it extending towards the zonules because it is highly uncontrolled step. Whenever you manipulate the flap, it is more controlled. But if you try to lift the flap, it is not well controlled. So let's start. Okay, so this is one concept that I try to explain to my students, and I will actually show it on the capsulorhexis edge. Now, from where you have torn the capsulorhexis, that you can consider as the pivot, and then where you are going to hold the flap can be considered as the lever arm. So I advise my trainees to hold the flap at the outer 1/3 and inner 2/3 junction, because that is the point which gives maximum control and there is no risk of creating unnecessary small tears at the capsule, the rhexis edge. So this is the best point to give you better control over the capsule rhexis. Now I give a rule of center of triangle. What is this center of triangle? So if you consider this imaginary triangle, which starts near the pivot until the capsulorhexis edge, and it's an isosceles triangle. So it's a symmetrical triangle, and you have to hold the capsulorhexis flap at the center of it. And when you hold it here, you will realize that you have much better control over the progress of this capsulorhexis than if you hold it far away or far closer to the edge. Just reminder again, I have already told you initially, if you push the capsulorhexis flap from underneath, just as you do at the start, it should be completely avoided because it may lead to uncertain tear to the periphery. So that is one thing which you must understand. So pushing up the capsulorhexis from this point, which is commonly what trainees do, should be completely avoided. And always keep the capsulorhexis flap flat on the anterior lens surface. The same rule of center of triangle should be observed when you are doing even the subincisional CCC. The same triangle applies. So here the common mistake what surgeons do is they try to hold a flap near the edge, that is the peripheral edge, because they feel that that way they have better control over this capsulorhexis margin. But that maneuver is little difficult because then you are trying to tint up your cystitome. And also you are not in proper control, because then cornea starts getting this dry. So it is better to hold it at the center of the triangle and then proceed. If you hold far away at this point, what you realize is that you get uncontrolled extension of the flap. Like in this case, the surgeon is trying to hold the capsule at far away from the center of the triangle, and he will get extension of the CCC like this. Now, to control it, you have to again adjust your cystitome to the center of the triangle and then pull it back. So let's see this in the video. As you can see, the surgeon has not changed the position of the cystitome, and that led to outward movement of the CCC. Watch here. He's trying to continue holding the flap from away, and the CCC tries to go out. So let's see entire CCC procedure in one go. So here I am making small 2 side port incisions. It is preferable to keep them small. If you want to do bimanual irrigation aspiration later, you can always enlarge it later anytime. This is the main incision. The usual viscoelastic that I use is again 2% HPMC, except in specific cases. Now, when you are doing manuals from the small side port, usually HPMC is more than enough for your regular cases. I am showing here how I have made the 45-degree cystitome using the 26 gauge needle. So I go from the side port here, start making a tear right from the center, make a radial tear around 2 millimeter, and then I lift up the flap. Again, now observe that I am following the rule of center of triangle, how I am forwarding the CCC. Very gradually, as I come in the subincisional area, that is a crucial area. Again, the same rules as you can see here, I have to follow. Hold it at the center of the triangle, not far away, not too close to the CCC edge, and then continue with the tangential movement of the cystitome. So this is the important area, because this is the part where many young surgeons tend to have extension of the CCC. So watch here, my 45-degree tip. I can visualize where it is holding the flap, and then I am proceeding further. Now I want to show the use of CCC marker also here. CCC marker is of 6 millimeter size. You can have this kind of ring and you can press it directly over the epithelium. If you keep the epithelium dry, this mark will stay for longer time. There is another option, it's called Patwardhan-Rexis marker, available with Epsilon, where there are small dented processes. So you can actually stain also these processes, and you may get 6 small dots on the corneal surface, and you can follow it to have rexis of around 5 to 5.3 millimeter. Always remember, when you mark the cornea, there is 12 to 15% magnification factor of the cornea. So when you follow those marks, you actually get a smaller size rhexis. So for 6 millimeter, it is around 5.2 to 5.3 rhexis size, which you get. Okay. Now, before I start the use of forceps, I want to explain to you this concept of how to do CCC using the main incision. That means the larger incision. Now, it is different than when you do from the side port. There is certain advantage that you have more maneuverability because the incision is large, but there is one drawback, and that drawback you have to consider when you are doing the manipulations through the larger main incision. So what is that drawback? Let's see. So if you see the cornea and the incision that we have made, this incision is self-sealing because whenever there is increased pressure from inside on the posterior lip, it seals itself. So when any instrument, cystitome or forceps, is inserted inside, and when you are pulling the anterior lip upward, it prevents leak of visco or fluid from the anterior chamber, because here the fluid will be pressing the posterior lip up, and that's why the wound remains sealed. So whenever you are using any instrument from the main incision, if you want to keep the anterior chamber stable, you have to always tent up the instruments, always. So irrespective of whether you are maneuvering away from the incision or in the sub-incisional area, you have to keep tenting up the instruments. So that you have to keep reminding yourself when you are operating. Because the moment you press the posterior lip down, you are going to break this seal of the incision and the visco or fluid is going to come out. So during CCC, you have to see to it that there is never posterior movement of your instrument. The posterior lip should never be pressed. So most of the forceps, except the micro Capsulorhexis forceps, you have to use the main incision for doing CCC. The other side of it is that for other movements, like for example, when you are doing hydrodissection, you may purposefully press the posterior lip to allow the fluid to come out. So just watch here how the surgeon is doing, and you can see that he's constantly pressing the posterior lip, and you can see the visco is slowly leaking out. When the viscose starts leaking out, you can see the bubble movement which is going out. That means the visco is leaking from the anterior chamber. And remember, which I showed you initially, when the anterior chamber pressure goes down, it cannot counteract the vitreous pressure and intralenticular pressure. And naturally, there is outward force which is acting on your capsulorhexis edge and which may lead to capsulorhexis extension. So this is the most common problem that you get when you start using the main incision. So now watch here carefully how the cystitome is tenting up the anterior lip. You can see here the anterior lip is being tented, and because of that there is no visco leak. Even if for the subincisional maneuvers also, you have to keep pulling up the anterior lip. And this is where the 3-bend cystitome helps, because it gives better ergonomic control over the anterior lip. Okay, so let's have a look at a video of Capsulorhexis using forceps. And I have borrowed this video from Dr. Nito Rosatelli. He is an excellent surgeon. And let's see how he does the Capsulorhexis. In expert surgeon's hands, everything looks simple, but the important thing is your control over the instruments and not pushing the posterior backward. Now, for using forceps doing CCC, the rule you have to follow is that your forceps tip should follow the size of rhexis. That means if you imagine the CCC, that's the circle that the forceps has to follow. And also look where the capsulorhexis forceps is holding the cut edge. It is not very close to the CCC margin, and it is not very far away as well. Now just look at another case. Here there is more vitreous pressure, and as you can see here, the vitreous starts leaking outwards. The surgeon here is expert, so he continues with the rhexis. But you can see here that visco is continuously leaking out. So at this point, what the surgeon has to do is push more viscoelastic so that the lost viscoelastic is again refilled in the anterior chamber, and then go ahead with forceps and trying to avoid pressing of the posterior lip as far as possible. So once you get control over your forceps so that you never press the posterior lip, you can get fairly good results with Capsulorhexis forceps as well. Okay, so now let's look at some of the videos. Let's look at some of the videos that I want to show you. Okay. So let me begin with another poll. In intermittent cataract, let's see what is your preferred technique. You can take around 15 seconds to poll. Five more seconds, I will wait. Okay. So as you can see here that around 50% are using aspiration of the cortex after cruciate puncture of capsule. Few are using spiraling, few are using double capsulorhexis, and few are not using any specific technique. All the techniques are very good if you understand the principle behind it. But my suggestion is that you stick with one technique and master it, so that you become, once you become master of one technique, you will get consistent results. So here, the technique which I am going to show here is basically the anterior cruciate puncture and followed by aspiration. So I will share some of the pearls how to use this particular technique. I think intuition cataract is the one. It can be considered the last challenge that is left for doing CCC, because once you are proficient in doing capsulorhexis and intuition cataract, then you can manage any other cataract with ease. So in a normal lens, as compared to that, in an intumescent lens, there is fluid which is filled, or the liquid cortex which is filled in between the capsule and the nucleus. And as its amount increases, it increases the intralenticular pressure. Of course, it changes from one patient to another. In few cases, it's liquid cortex. In few cases, it is the entire lens which is swollen and we cannot aspirate much. So in order to reduce the intumescence, what you have to do? First, we have to prepare the eye for the first nick. I think that is most important, because if you see the Argentinian flag sign, it many times happen when you nick the anterior capsule first. Once you nick the anterior capsule and the Argentinian flag doesn't appear, then it is unlikely to appear later if you reduce the intralentricular pressure. So any technique of doing capsulorhexis in intubation cataract is good, but most important thing is you have to prepare the eye for the first nick. And how will you prepare the eye? To prepare the eye, somebody is trying to chat with me. I will just pause for a moment and I will start again.
Hello. Hello.
Hello.
No video, sir, on the screen.
You cannot see anything?
Yes, sir. No video at all.
Okay. Just one moment. I will try to correct it. Okay. I think now it's better.
Yes, sir. Yes, sir.
Okay. So I will begin again. So as I was saying, we have to prepare the eye for the first nick of the anterior capsule. So the principle behind is that the anterior chamber pressure must match the intralenticular pressure. And if you remember what I told earlier, pushing methyl cellulose excessively in the anterior chamber is not going to address that. Why? Because when you are pushing too much of methyl cellulose in the anterior chamber, as I told earlier, it is going to stretch the eye and the vitreous pressure in fact is going to increase, which is going to push the lens forward. So that is not the answer. If you want to prepare the eye for the first nick, you have to use a high molecular weight viscoelastic agent like Viscoat or 1.4 or 1.8% hyaluronate, because it can increase the anterior chamber pressure or the weight over the anterior capsule without increasing the vitreous pressure. So let's start with the step 1, where I'm going to make very small 2 side port incision, because that is going to help me in maintaining the anterior chamber much better. If I use the large main incision, yes, I may be able to do CCC in few cases, but not in all, because there is always chance of visco leak from a larger incision. This chance is less from the small side port incision. So first part is making this side port incision, making the main incision, and then staining of this anterior capsule. As I mentioned earlier, few studies have shown that staining reduces elasticity and increases the stiffness. So just watch here the surgeon trying to do rhexis in an intubation cataract from the large main incision. Obviously, the rhexis goes out because now there is no counter pressure against the intralenticular pressure. So the second step is, as I was explaining, balance the intralenticular pressure by using higher molecular weight OVD. There are 2 ways to use it. You can use the soft shell technique, where you are using high molecular weight dispersive like Viscoat or Hylucoat initially, and underneath you are using high molecular weight hyaluronate like 1.4 or 1.8%. Nowadays, I use only dispersive agent because I found that that is more than enough. You don't need hyaluronate. So what I use is I use combination of chondroitin and hyaluronate, which is Viscoat or Hylucoat. And I fill entire chamber with that. in this video, I am going to show the soft shell technique. Many surgeons ask me, why not use only methyl cellulose? Yes, you can use methyl cellulose, but then the repeatability of the procedure is less. The third step is making cruciate puncture. The simple principle behind this is that because you have made cruciate puncture, 4 different tears are there. The whatever intralenticular pressure is there is not going to act on a single tear. So the chances of it extending to the periphery is less. So if you make a single tear, there is a high risk of extension. So you can make a cruciate. Some surgeons use a C kind of tear, which is also okay. But I think cruciate makes more sense because there is a lesser risk of radial extension. So this is the cruciate incision. Just see that the anterior chamber is completely closed because I'm using the side port. Second, the anterior chamber pressure is good because I have used the soft shell technique. And what I'm doing here is that after making the anterior cruciate incision, I tapped the nucleus down a little bit so that the fluid which is behind the lens nucleus also starts dispersing anteriorly. So now we come to the fourth step, which is decompression of the lens. So how to do that? We use 27 gauge cannula again from the side port. So again, I am going to maintain the anterior chamber. I am going to aspirate the fluid. I am going to tap also the nucleus down as I shown here, so that the fluid which is behind the nucleus also comes up around the equator. And you can actually see that the anterior capsule is getting more and more flattened. And you always do it from both sides so that the liquid cortex which is trapped gets cleared from both sides of the tear. Otherwise, you start rhexis from one side and you end up tearing on the other side. So always do it on both sides. And this is a very important step. It is called strokes from the periphery. I have seen this technique being used by Dr. Phaco from Singapore, and I find it extremely useful. Now here what we are doing actually is that we are not necessarily injecting viscoelastic, but little bit of viscoelastic over the anterior capsule, and then press the peripheral capsule towards the center. So the cortex which is trapped or in form of pockets which are there are now getting released, and the anterior capsule is becoming flatter. And again, if you remember the first principle, if the anterior capsule is flat rather than convex, the outward forces of on your Capsulorhexis edge are less. So once you flatten the anterior capsule, you will find that it is much easier even than a normal cataract to do CCC in intumescent cataract. Now you can do a small rhexis like you said in double rhexis. You can make first a small rhexis and then you can make tangential cuts with vanas, and then you can enlarge the CCC later by using forceps. This can be done either after removal of the cataract or you can do it before also. After you have removed all the intumescence, you can do it. And also after putting the IL also, you can refashion the CCC as you want because there is no intumescence now. So you can easily manage the CCC. Okay. So now I'll be showing the next case. I hope the video was seen now. So I will now share the next video, which is there. And I'll be talking about the CCC retrieval techniques, which are there.
राणू फार सुंदर रंगवलं.
Just wait for a moment. I will upload the video.
उद्या अभ्यास नाही सकाळी रविवार ना.
Okay. So, as we all know that CCC is very essential for doing Phaco, and particularly for young surgeons. I think once the CCC is extended, we don't proceed with Phaco because there is obvious chance of Rexis extending further and nucleus drop. So we have to somehow complete the Capsulorhexis. So there are a couple of manuals which are of use when your Capsulorhexis is trying to extend. First, very famous and very useful manual, it is called Little's Technique, described by Brian Little and his colleagues. So here basically what we are doing is that if the Capsulorhexis is going out, we are flattening, unfolding the flap, and then we are pulling it backward rather than tangentially. So once the tear is inside, then we can complete the rexis. But I found that this Little's technique is not used when the CCC has already extended into zunules. Then many times, if we try to pull it back by Little's technique, it doesn't come back. So in such cases, the technique that I use is called quick pull maneuver. It was described by Dr. Nito and his colleague. I will show the paper also. And these are other techniques that many surgeons use, that they just leave the extended rexis and then they complete the rexis from other side. But then this CCC is incomplete and there is always a chance of complication. You may use either vanas to cut the rexis flap, or as I shown previously, you can make a nick at the edge of the CCC and make another rexis from other side. But again, it is incomplete rexis. So what is this quick pull technique? So we'll see some of the cases. So this technique was described by Dr. Coelho and Dr. Rosatelli and his colleagues. So there is a quick forward movement with force applied in the plane of the anterior capsule. So it's a quick central pull on the anterior capsule. Most important thing is it has to be quick and it has to be exactly centrally. So once OVD is filled again, it is better to use viscoat. You have to hold the Capsulorhexis flap, which is extending into zonules. Once you hold it firmly, just pull it quickly towards the center. If you try to pull it very slowly, it tends to extend even further. So it has to be done with certain speed so that it comes back and you get a complete Capsulorhexis. We'll see again in another case. Now watch here how to exactly do it. So the rexis has already extended. The surgeon is trying to retrieve it initially with little maneuver, and now he's trying to do quick pull maneuver, but see his force is tangential rather than centrally. You can see here he's trying to still pull it tangentially, then it is not of use. So in order to make it work, you have to go from the opposite side and then pull it centrally very firmly. Now I am using small microcapsulorhexis forceps, holding the flap from the other side, try to unfold the flap completely, and now pull it quickly. So you can see the rexis is now coming back. Now I'm going from again main incision and again pulling it quickly so the rexis comes back. And it is surprising how many times even we feel that the rexis has gone out, but it still comes back with this quick pull technique. Of course, it breaks few zonules in that area, but then you can complete Phaco and place IOL in sulcus. So again, another case, the initial attempts, again you can see the mistake being done. Now you can see the surgeon is pulling it centrally, but not very quickly. So again, I am going from the opposite side, holding the flap and pull it quickly. You can actually see the zonules got broken and then the Capsulorhexis came in. You can see here, as I pulled it, the zonules which were holding the rhexis back got broken. And once they were broken, the Capsulorhexis came in and we could complete the Capsulorhexis. So I think this is one of the usual useful techniques. I will show it in some other videos as well. I will load the next video. The video is named Red Flags in Capsulorhexis. So let's see what are the red flags. Let me share the screen, just a moment. Okay. So what are these red flags? Let's have a look. So it's a case of white mature cataract, little bit intumescent. So I'm going to follow the same principle which I explained. I've just fast forwarded this video because we want to go directly to the red flag. I'm using sodium hyaluronate here, the soft shell technique. The cruciate punctures will be made on the anterior capsule. Then I will aspirate the intralenticular fluid from both sides, remember. Then I will flatten the anterior capsule by giving the stroke using the visco cannula. So the anterior capsule is flat now. And now I'm going from the side pore to do the rhexis. Quite easy now as compared to initially because now the lens intumescence is less, but still keep watching the Capsulorhexis age. Okay, what do you see here? You can see the Capsulorhexis age has changed its direction. So this is one red flag. Once you see it, you have to immediately stop and then replenish the anterior chamber with good viscoelastic agent. Though we are far away from the zonular area, we don't want the direction to go that way. So it is better to prevent it from going that way. So now I have again deepened the anterior chamber a little bit. And now I'm pulling the Capsulorhexis. Now it came in, there was no extension from that side. And I could complete the rhexis easily. So this is a red flag. So we should not miss these red flags so as to achieve safe Capsulorhexis in all cases. Now let's look at another case. So watch here, the surgeon is very cautious. He is pushing the flap slowly, but watch how closely he's working at the edge. If you consider the rule of triangle, he's not following that. He's trying to catch the rhexis at the edge, and his tip is not very visible because the flap is covering it. So the flap is not flat on the anterior capsule. The tip is not visible, and he is touching or pulling the Capsulorhexis flap very near to the edge. And what you see here, I felt there was a V-shaped tear there. But the surgeon was quite confident. He said, no, I completed the rhexis. I don't think it's just maybe some disturbance in the cortex. And as he said that the rhexis is now complete. So let me proceed with hydrodissection. So he went in, pushed some fluid, the flap was free flap, so it came out. Very good. So now he is proceeding with hydrodissection, and now he is trying to rotate the nucleus, and he could rotate it. And now what happened there? So the Capsulorhexis extended from that side. And why it happened? Because of the three things which I mentioned: not following the rule of triangle, not keeping the flap flat on the anterior capsule, and not visualizing the tip of the cystitome. Let's look at another case. Watch here, the surgeon is doing and pressing on the posterior lip of the incision. Visco is leaking out little bit. As you can see, the CCC is trying to become bigger and bigger on its own. The surgeon is experienced, so he pulls it back. But again, he is not replenishing the antechamber with visco. So there is always an outward pull. See here, there is an outward pull on the Capsulorhexis edge. So this is what happens when the visco leaks from the antechamber and you are lazy not to replenish it. Of course, he could pull it back with little manure, but you have to understand it. It is a red flag if the antechamber is becoming shallow. Now again, another very careful trainee surgeon is doing his rhexis. He is fully focusing on the Capsulorhexis margin here, proceeding very slowly to continue with the CCC. And what is he missing here? Can anybody tell me what is he missing here? What are the problems or what are the things which he is not looking at?
Sir, surgeon is pulling the flap from the edge, not from the market, not from the triangle.
Perfect. That is one. Anything else? Correct. 2/3, 1/3 not maintained. So he is not following the rule of 2/3, 1/3.
Sir, cystitome is not pulled up, not on the anterior flap. I guess the surgeon is pressing on the posterior scleral lip.
Okay. Fortunately, he is doing from the side port, but yes.
Okay, sir.
Okay.
Correct. Yes, sir.
Okay, let's proceed and see what exactly. Yes, so someone has given the answer. So this is what the surgeon is seeing, very focused on the Capsulorhexis edge. Still, he, as you mentioned, he is not following the rule of center of triangle, too much in the periphery. Now look at the center. He is far away from the center. Okay, he is into periphery. Because the pupil is well dilated, he underestimated the size of the rhexis, and rhexis obviously went out into zonules. And why did it go into zonules? What are the reasons here? Can anybody explain? So why did this CCC went into zonules?
Hello.
The first slide, initial slide, yes, which I mentioned, whenever the rhexis is larger than 6 millimeter, there are more outward forces on the Capsulorhexis edge because now zonules are pulling it outside. Okay, so when you are doing very large rhexis, obviously there are higher chances that it is going to go outside, and of course the rhexis is now eccentric. So now what to do? So the surgeon again, see, he is not following the Little's maneuver here. Maybe he's trying to do that, but now he left. So now I am going to do a quick pull maneuver. See this, how I pulled it back from the zonules very easily, and then I completed the rhexis. So whenever you are doing Capsulorhexis, also look at the bigger picture. Also imagine the size of the rhexis, and for this matter, I think for the initial cases, Capsulorhexis marker is very useful because you then know the size of the rhexis. that you are looking at and whether you have crossed that 6 millimeter risk or the zone, and are you going into periphery. That is very useful. Now let's look at the next case here. Surgeon is very confident. This trainee has done many cases now and very confident with the rhexis. So completed the rhexis. That's what he thought. And now he's going to do hydrodissection here. Can anybody tell me what was the mistake that was done? Anyone? Yes. Yes. Very important. The rhexis is not complete. Okay. He didn't remove the flap. He thought that the rhexis is complete, but watch here. The flap is still there and rhexis is incomplete. Luckily for him, it didn't extend out, but I think it is better to be cautious and remove the flap to confirm that the rhexis is complete. Okay, so these are few red flags that we should always be looking at. And even in expert surgeon's hands, if he tends to neglect these red flags, he tends to get more complications. If there are any doubts so far, we can have a small question answer session now. And the next topic is on Morgagnian cataract. But if there are any questions, please go ahead. You can unmute yourself and ask me the question. So let's take 1 minute break here. So if you have any question, you can write in the chat, or you can also unmute your mic and ask.
What was the literal
Okay,
technique you demonstrated?
Dr. Tripti has asked, can you repeat the Little's maneuver once more with cystitome? Yes, of course. I think Little's maneuver is very useful, but I personally found that once the CCC goes into zonules, with Little's maneuvers, sometimes you don't achieve the same thing which you can achieve with quick pull. Dr. Sabha wants to ask, when it extends, can it pull it with capsular forces, not microcapsulated forces? I think that's what he wants to ask.
I'm not ready to.
You can use the regular Capsulorhexis forceps as well. But as I told, it is useful to do maneuvers in the closed chamber than through larger incision, because there is always chance of visco leaking out. But you can do it once you have got good control over the Capsulorhexis forceps. You have to follow the same principles which I told you initially, to keep pulling or tensing up the anterior lip of the incision. One participant has asked, small pupil and not sure about the extent. So how to proceed? Few tips. Okay. I think the simple rule for small pupil is that don't keep it small. So you can use either a pupil expander ring, or you can use iris retractors, even intraoperatively, if there is an intraoperative meiosis or intraoperative constriction of the pupil. So if you have small pupil, first enlarge the pupil, either try intracameral adrenaline or iris retractors or pupil expander ring, and then only proceed with your case, because there is no point in making it hard for you by keeping the pupil small. Okay, I think okay, I will proceed now with the next video, which is on Morganian cataract. Now, Morganian cataract is not very common, but not that rare also, particularly in Indian continent. And in Morganian cataract, the difference is that all the cortex is already liquefied. So there is no support for the entry capsule. So I will show a couple of cases and let's see how I do capsulorhexis in these Morganian cataracts. The capsule is sometimes brittle and the cortex is all liquefied. You can see the nucleus is shrunken. Here, my choice of instrument is microcapsulorhexis forceps. Of course, you can use the regular capsulorhexis forceps. And here, I want to show you the principle of shearing. So see, I am moving my forceps tangentially, always tangentially. So the shearing force is used and not the tearing force. This is very important, particularly when the zonules are weak. Now, in the same case, we'll see if instead of shearing, I start using tearing force, see what happens. So here I made first a smaller rhexis and now I am spiraling it out. Again, I am using the shearing forceps. So far, very good. I'm continuing. The liquid cortex keeps coming out. So we have to keep pushing viscoelastic. Here there is no intumescence, so I'm not worried about the intumescence. So again, I go in with capsulorhexis. And again, tangential. Now watch here, what I do. I suddenly become a little bit lazy here. And instead of giving tangential force, I start tearing. See what happens? The rhexis goes out because the zonules are getting pulled in. So luckily here, I could retrieve the rhexis, but this is not a good idea to do in Morganian cataract. Now, this is another case of Morganian cataract. Again, here I am going to show why I don't prefer to use cystitome. Because unlike capsulorhexis forceps, to use cystitome, we need good support of the nucleus. That is quite essential. As you can see here also, the cortex is all liquefied there. In Morganian cataracts, I always use good OVD like Viscoat so that the pressure is maintained over the entry capsule and the flap remains down. Now see, I am trying to use cystitome here. Now watch what happens. So here I could raise the flap. I could push the flap back a bit. So I have flattened the flap now. I'm going ahead with the capsulorhexis. So I continued with cystitome because I thought that, yeah, in this case I can do it. But now watch here. It just extends. Can somebody tell me why it extended? you can see the nucleus has moved to one side, and obviously there is no support for the rhexis using cystitome there, so it went out. So that's why I think for Morgagnian cataracts, it is better to use Capsulorhexis forceps. So in this case, I could not retrieve the rhexis back. So I made a nick on the other side and complete the rhexis. But of course, on that side, also, as I mentioned, for using the quick pull maneuver, the zonules have to be healthy. So in case of Morgagnian cataract or where the zonules are weak, we should not use quick pull maneuver because it will lead to dialysis. So in such cases, it is better to leave it like that and complete the rhexis from the other side. Okay, I think there is one question about role of pre-op mannitol in case of Morgagnian cataract. In Morgagnian cataract, I don't think there is any role because there is usually no increase pressure in the vitreous in Morgagnian cataract. In intumescent cataract, some surgeons do use it before the surgery. I personally don't use it in all cases. But in the case of phacomorphic, of course, we have to use the IV mannitol before surgery. Okay. So now the next case, next rhexis is in pediatric cataract. So I think I will take that as the last case and we'll proceed with the other types of CCC in the next chapter. So we'll start that. If there are any other questions, you can keep writing. Again, the role of acetazolamide, I think it was asked for, again, intumescent cataract. I think many surgeons do use it. So if you find it is of use, you can use it. I personally don't use Dimox or IV mannitol preoperatively, but there is no harm in using that. Okay, so let me proceed with CCC in pediatric cataract. Yes. Now, if you consider the first slides about the rules, just remember that pediatric cataract, the sclera is elastic, the anterior capsule is elastic, the zonules are elastic and quite strong. The anterior lens surface is highly convex. So everything is against you. That's why there is a high chance of CCC extension in pediatric cataract. The OVD of choice for me is 1.8% sodium hyaluronate. I think it is extremely important to use good OVD, particularly in pediatric cataract, because CCC is something which is the main essence of the pediatric cataract surgery. Again, I'm using the side port incision, first creating a nick, using the cystitome. You can also continue with cystitome, but I find that control over the Capsulorhexis age is better with micro Capsulorhexis forceps. Again, watch here how I'm doing. So as far as possible, we have to keep pulling it centripetally. If you try to pull even little bit tangentially, that means use the shearing kind of force, you will find the rhexis is going outward. That is because the zonules are quite strong and elastic, and they tend to pull this torn edge outside. So you have to keep on using the tearing force here. The moment you use shearing anytime in between, you will find the rhexis is becoming larger. So only if the rhexis is becoming very small, you have to use the shearing force very little bit, and then again go back to tearing force. So this is where the tearing is more important than shearing. And always hold the Capsulorhexis edge, the torn edge very close to the torn margin. Though never hold it far away from the Capsulorhexis edge because it tends to go out very quickly. Again, just another case. So using 1.8% sodium hyaluronate here, and now starting the rhexis. You can also proceed with acetone if you feel confident using it. But as it involves more of shearing force, as I said, whenever you use shearing force, it tends to become larger. So watch here now, I'm using shearing force in between and it started going out. So I have to use strong tearing force here and pull it back. But the moment it starts going out, it will become bigger no matter what you do. So the CCC has become bigger here, but luckily it's not torn, it's complete. So we can proceed with safe surgery. Another technique that is used in pediatric cataract is posterior capsulorhexis. And interestingly, it is easier to do than anterior CCC in pediatric cataract. The main principle that you have to stick to is that always keep anterior chamber well maintained, and the posterior capsule should always remain concave. That's the idea. So I have made a small nick in the posterior capsule here. You can see the small nick here. And now I'll push some hyaluronate through this nick so that the anterior hyaloid gets separated. You can see the small bleb which is being formed there, indicating that anterior hyaloid is separated. You can also make a larger bleb. And now I go in with microcapsulorhexis forceps. And the movements are similar to anterior CCC, but here the posterior CCC tends to be smaller than what you expect. So you can try to enlarge it a little bit. You need around 3.5 millimeter posterior CCC here. You can see it is quite easy to do. Only one thing you have to make sure is that never allow the anterior chamber to prolapse, because the moment anterior chamber collapses, the anterior hyaloid becomes convex and it gets torn. And then vitreous will prolapse in the anterior chamber. So that is the only thing which you have to avoid. So that's the end of the videos for this session. I will use some other session to discuss other videos. Now there are some questions on YouTube. I will just answer those questions. Just wait for a moment. In the meanwhile, if you have any question, you can type in the chat. Okay, there is one question about rhexis in case of a dense and brown cataract for SICS. I think the same principles have to be used. And when you are doing a brown cataract, particularly SICS, you have to make at least 6 mm rhexis. And that is the difficult part. If the cataract is black or brown, it is better to stain it very well. So you keep the dye for at least 20 seconds so it stains. You have to ensure, if possible, use good OVD. Again, use the small side port incision so that the antechamber remains maintained, so that you can make larger rexis. Always go a little slow when you are making larger rexis. Always make sure antechamber is well maintained. If you find the rexis going out anytime, you should keep the forceps ready, and so that you can use the quick pull maneuver or littles maneuver. So these are the tips. Otherwise, you have to follow the same principles. So thank you very much, all the participants. Do send me feedbacks. If you have any doubt, you can anytime ask me. You can subscribe to my YouTube channel, Sourabh Patwardhan Phaco Tips, so that you can ask me any questions on videos. I hope it was useful to all. I tried to give how the surgeon should think, because there will be many more situations that you will encounter, many more as compared to what I have shown. So do consider that your concept should be more clear, so that you can tackle any case once you know the physics and chemistry and the forces acting on the capsule inside the eye well. There is a question: what is the cutoff pressure for doing cataract surgery in Morgagnian cataract? I think Dr. Adarsh, he wants to ask the question about intumescent cataract or maybe phacomorphic cataract. It is better to have intraocular pressure as normal as possible. So give IV mannitol, give oral acetazolamide and control it. Also, before surgery, you can block the patient and give ocular massage. Because as you know that when you are operating in a globe with high IOP, there are always high risk of complications. But in case it is not getting controlled, then you can always do guarded compression. I in fact didn't show you one video, the case of phacomorphic glaucoma, and it went into chronic closure and the IOP was not reducing. So in that case, I did controlled vitrectomy, core vitrectomy first, reduce the IOP on table very gradually, and then I continued with CCC, but these are rare occasions. There is another question: in extended rexis, when to decide to shift from Phaco to SICS to prevent more harm? It is very interesting, I would say. In case of extended rexis also, it is quite safe to do Phaco if you are experienced and you know the principle behind how to do Phaco in extended rexis. The principle behind Phaco in extended rexis is that never raise the anterior chamber pressure above 35 to 45 centimeters of water. So it is as if you are doing small incision cataract surgery. You can see my video on Phaco in extended CCC, that is on my YouTube channel in my playlist. So you can watch that. You have to do all maneuvers very carefully so that you don't push anything down when you are doing nucleus separation, nucleotomy, and other maneuvers. And you can very safely do Phaco in extended rexis. But yes, if you are a beginner and you want to be on safer side, if you feel the rexis has gone beyond the equator, that is seen when the fold of the CCC margin, you know the sign, when it turns inwards, then there is a chance that it has gone behind. At that time, it is better to convert it to SICS. Dr. Ritvija, I think I have streamed the Zoom meeting on YouTube. So if you subscribe and to my YouTube channel, I think the recording should be there. Let me check if it is good. I will see whether the audio is there or not. Otherwise, most of the videos I presented here are already there in my Phaco training playlist. So you can watch those videos there. Of course, I have added few things in the initial part. The initial part is in fact most important thing because based on that, you can tackle any case.
Just don't know what I'm talking